Hi, everyone, and welcome to Your Health Now. Today, we're going to be talking about polycystic ovarian syndrome and its possible treatments.
That's right. So we're going to start first with fertility. So we know that a lot of women with polycystic ovarian syndrome may not be ovulating regularly, and it may be difficult for them then to achieve a pregnancy if they're not ovulating each cycle. And there are a number of things that we can do to improve fertility in women with polycystic ovaries. So the first thing really is lifestyle change. So for a lot of women, eating healthily, exercising regularly, being active, all of those things can actually improve the inner metabolism, if you like, of the body, and that will help with the insulin resistance that we talked about earlier and helping the ovaries. So there's a link between the excess androgens or testosterone-like substances and insulin resistance with fertility. And so it seems that if we improve the perhaps weight of women, if we can somehow optimize their weight and their healthy lifestyle, then that can go a long way to regulating periods. The next step, if we're not really winning with that, is to think about a medication called metformin. And you may find that a lot of us will actually use metformin sooner rather than later, and maybe even at the same time that we're introducing the lifestyle changes.
So, some great resources. We'll be discussing lifestyle and healthy eating and exercise more in upcoming videos. But some great resources where you are can be your local dietitian or exercise physiologist or your family health practitioner, health worker, nurse practitioner, whoever your first point of contact would be. So to find out more how that might where you should start, those would be some really great people to refer to.
Absolutely, yeah. And look, metformin's not for everyone. Obviously, it's a medication. There are some side effects, but in general, it really does help women to ovulate more regularly by addressing this underlying issue of insulin resistance and also just improving the metabolic state of women with polycystic ovaries. So that's a very important part of it. The next step, obviously, is going into the assisted fertility arena. And for that, really, your primary provider would generally refer you to a specialist in fertility medicine, and there are different options open to you there. So sometimes it can be as simple as another medication called clomiphene or Clomid that can stimulate ovulation and timing sexual intercourse appropriately. Sometimes we may well actually need to we always need to check your partner. This is the other thing. Be very careful that your partner is also checked for fertility at the same time, because you do not want to be, a year or two down the track into any kind of assessment and then find that your partner has issues as well. And all the work that has been done to try and improve your fertility, unfortunately, hasn't helped your partner. So really that your partner must be assessed at the same time. And there may well be some insemination. Sometimes we do assisted insemination where your partner provides a semen sample, and that can then be introduced into the uterus right at the point of ovulation or soon after ovulation to improve the prospects of pregnancy. And then moving on from that, there is obviously the IVF or in vitro fertilization, or ICSI, which is some of the other techniques that we use. There's a lot more techniques now. There are still some surgical techniques that are used for women with polycystic ovaries, and that involves a laparoscopy, so a keyhole surgery, where sometimes the cysts and the ovaries are actually modified by the surgeon, the gynecologist, to improve ovulation physically. So there are quite a lot of options there when it comes to fertility. But many women with polycystic ovaries, we now know, will conceive with some simple interventions such as lifestyle, metformin, maybe some clomiphene, and many don't actually need to proceed to in vitro fertilization or the more technical fertility treatments, which is really nice. So that's the fertility side of things. And then the next point really is endometrial protection, which we mentioned earlier in our previous video. And this is because we know women with polycystic ovarian syndrome have a higher rate of endometrial cancer or uterine lining cancer. And so we're very careful that women with polycystic ovarian syndrome are actually turning over their uterine lining, and we do prefer them to have some sort of therapy that involves progesterone, because we know that that protects the lining of the uterus. So that could be a combined oral contraceptive pill, estrogen and progesterone, or we call them estrogen and progestogen, or it could be an intrauterine device such as a Merryn IUD, which has progesterone in it. There are lots of options there. And again, that's worth having a chat with your primary healthcare provider about, or a gynecologist or endocrinologist, or someone who has a good awareness of polycystic ovarian syndrome. So that's an important part of it. Also the metabolic side of it. So we talked before about the insulin resistance, and it'd be worth having a look at our first video where we talk about that a bit more, if you haven't seen that already. But essentially the insulin resistance, again, we treat that with lifestyle change, so good eating plans, exercise, activity, and then metformin is a really good option. And that really addresses a lot of the insulin resistance. Trying to keep a healthy weight is a part of that. And then while we're talking about weight, there are some new medications that we have available to us, such as GLP-1 analogues, and you may well have heard the names of some of these, exenatide or Byetta, liraglutide or Saxenda. And these can be used as well to assist with weight management. We've got to be very careful that we don't forget about the spin-offs of carrying a bit of excess weight, such as obstructive sleep apnea. So women with obstructive sleep apnea, where you snore and stop breathing at night, are actually losing oxygen to their brain on a regular basis overnight, and that really needs to be assessed with a sleep study. So if you're snoring, then it's a good idea to ask your practitioner for a sleep study, because we know if you get more oxygen to your brain, then you're more likely to think clearly for a start during the day and be safer at whatever you're doing. But also it assists with weight management. It assists in keeping your body healthy, decreasing your risk of blood pressure, high blood pressure, and high lipids and other things. So very important to make sure that your sleep is optimal as well. Even if you don't have sleep apnea, make sure you get enough sleep. I know a lot of us women are sleep deprived a lot of the time. And so moving on now from the weight side of things, there is that increased risk of diabetes. So we know women with polycystic ovarian syndrome have a much higher risk of developing gestational diabetes in a pregnancy, whether or not they're overweight. So you can be a very slim lady with polycystic ovarian syndrome and develop gestational diabetes in
So
your
would you
pregnancy.
test earlier in the pregnancy?
Absolutely. That's our current recommendation.
How early?
So
Is there a
we try
guideline?
not to test so early that we're going to make people sick, because the test itself, this glucose tolerance test that we use at the moment, can make women quite sick. But we do try to test in that first trimester if we can. But if women are very sick with a lot of nausea and vomiting, that really will affect the test. And so we want to try and do the test as early as possible, but without making them too sick. So if they're very sick, sometimes we'll wait until we're at maybe 13 to 16 weeks as opposed to earlier. But yes, we are erring on the side of caution and testing in that first trimester for a lot of women, or certainly early in the second trimester. And then they get tested again at the 28-week usual recommended time. The other point I might just make is that gestational diabetes is not magically, it doesn't magically appear at a certain time in the pregnancy. So a lot of women may develop gestational diabetes after the 28-week test. And so if there's any doubt, we may well occasionally ask women to be checking blood sugars after 28 weeks, particularly in polycystic ovarian syndrome, even if they tested well on the 28-week glucose tolerance test, because they can develop it a little bit later on in the pregnancy. And that's important for the size of the baby, because the baby can be larger if there's gestational diabetes, and then that will increase the risk of adverse pregnancy outcomes. And I should just point out too, Laura, that polycystic ovarian syndrome is a risk in itself. So women with polycystic ovarian syndrome must be seen as a higher risk pregnancy and must really be seeing healthcare practitioners during their pregnancy that understand that increased risk. So not only is there an increased risk of diabetes in pregnancy, but there's also an increased risk of high blood pressure in pregnancy, preeclampsia, and preterm delivery. So, and the babies born to women with polycystic ovarian syndrome often need to go to the special care nursery more frequently than babies born to women who don't have polycystic ovarian syndrome. And this is all independent of weight. So whether you're a slim lady or a larger lady, it doesn't matter. If you have polycystic ovarian syndrome, it is a higher risk pregnancy. And because we're aware of that now, our pregnancy outcomes are so much better. So I just want to reassure you that just because you're a high risk pregnancy doesn't mean there are going to be adverse outcomes. If anything, it probably means there will be less because you'll be closely monitored.
That's fantastic.
Yeah.
Very reassuring.
Absolutely, yeah. And so then moving on into that kind of longer term risk, if you like. I have polycystic ovarian syndrome. I had diabetes in my pregnancy. We know that if you have diabetes in your pregnancy or polycystic ovaries, you're going to be at higher risk of type 2 diabetes. And so we suggest that you get regular checks, and we always check, if we can, 6 weeks after a pregnancy to make sure that any gestational diabetes has resolved. Sometimes that's not quite realistic with a young baby or twins or multiple birth, and so you may well delay it a bit, but you need to get it done absolutely as soon as you can after the pregnancy.
I think it's often missed.
It is often missed, and that's something that you probably need to carry in your own head to remind your healthcare practitioners that after that pregnancy you must be checked as soon as possible, not within the 6 weeks, but certainly as soon as possible after the 6 weeks, and then preferably annually thereafter. And what kind of test you have will depend upon your polycystic ovarian syndrome and also where you're at with your other healthcare issues. So you may well need a glucose tolerance test every 1 to 2 years, but sometimes we find that women are fine just to have a fasting blood glucose test, maybe a C-peptide and insulin level, if that's something that their practitioners are using and able to interpret. In some places we will use an HbA1c as well, though that's not commonly used at the moment for screening. So that's really important that for the rest of our lives we need to be having these regular diabetes checks, regular cholesterol checks, and if your cholesterol is up, then it absolutely must be addressed. So pretty well, cholesterol really should be checked 6 to 12 monthly in women with polycystic ovarian syndrome. And we do still use the same targets in polycystic ovarian syndrome as we do for women with diabetes and women with blood pressure and other health issues, heart issues and those kind of things. So we like that cholesterol to be as close to 4 as possible. And certainly if you do have blood pressure or diabetes or anything else below 4, and we like to see the what we previously called the good cholesterol, the high density lipoprotein or protective cholesterol, in a nice healthy range, not too high, because we know now that too high is actually not a good marker, it's a risk marker, but certainly in the healthy range. And the low density lipoprotein, this cholesterol that we see as being atherogenic or blocking arteries, that cholesterol, we like that to be below 2 if possible, and in some women below 1.8. And the triglycerides, again, are very important in women with polycystic ovarian syndrome. We like those to be in a nice healthy range, and a lot of people will aim for below 1.5 for those, but certainly below 2 or 1.8. But 1.5 often you'll see us trying to aim for in lipid profiles. So we're hoping that by improving these parameters now and healthy lifestyle now, we can prevent heart attacks and strokes and other issues in women with polycystic ovaries longer term. So I often say to people, you know, as distressing as it is to have any kind of healthcare diagnosis, this one I feel is one that if it's being addressed well, it may well be the best thing that can happen to you, because you may well be a much healthier older adult than a lot of people around you who didn't receive all of this preventive care prior. So we have a lot of hope around polycystic ovarian syndrome and outcomes now, because we're so much more aware, and I think women are really very empowered by that knowledge.
And I think the stigma of it has been reduced as well.
Absolutely.
You know, I think that
that's right.
that, you know, and of course it's the same with diabetes, but finding that you do have insulin resistance or you do have PCOS, I think in general we're all worried about labels.
Yes.
You know,
Yeah.
but I think that's all changing now, and and as women, it's so important to take charge and act early on our health, because, you know, we're all so busy taking care of everyone else quite often that we forget to take care of ourselves. So, you know, hopefully this video has also been really helpful and empowering and informative for you.
And I just want to add one more thing. I would love it if we as a group of women could come up with a new name for this condition.
Yes.
So the name polycystic ovarian syndrome, I think, is very, very misleading. And because really it's a syndrome characterized by hyperandrogenism of the ovaries, or ovarian hyperandrogenism. With metabolic syndrome. But I think if any of you have any ideas about what we could call this, please let us know, because we would love to start a campaign to rename this condition. And I think too that would help with this previous stigma and really empower us as women to rename this condition so that it's hopefully better recognised, diagnosed early, and managed to a very high level, so that we can improve the quality of life of women with polycystic ovarian syndrome wherever they are in the world. So please let us know if you have any ideas. We would love to hear them.
Our email is down below. Thank you, everyone, and thank you for watching our video.
Thanks so much.
Thank you.